Uh, on behalf of Neonatology Unit, BLK, I am Dr. Vikram presenting an interesting case which has been encountered in NICU. So as we know, the twin pregnancy have higher morbidity, mortality rate as compared to single pregnancy, the cause of which can be defined as due to prematurity, low birth weight, and the chorionicity, which is an important factor seen in the twin pregnancy. So as we know, there's a unique placental architecture of monochorionic twins, which makes different from a single twin or dichorionetic twin, which sir,
Yeah, please continue, Vikram. मैंने mute कर दिया संजीव.
due to unique placental architecture of monochorionic twins, which carries a higher risk for developing severe complication. The because monochorionic twins has a single placenta which is shared by both the twins, as compared to dichorionic twins, which share a different placenta, which makes them less develop complication. So recently, we have encountered a case of monochorionic twins with the development of complication, which is a unique in nature. After searching some literature, so we are presenting this case because of its rarity of the case and to raise the index of suspicion for the further cases to enable proper evaluation and management of the further cases. The case is a set of female twins which is delivered to a 40-year-old multigravida who is a booked case and naturally conceived and who is antenatally diagnosed monochorionic twins on ultrasound scan during the first trimester at around 12 weeks with a history of PIH, pregnancy induced hypertension. The pregnancy was serially followed up on further antenatal visit, but on in third trimester around 32 weeks we revealed abnormal Doppler changes in the form of increased SD ratio in ultrasound scan with showing normal amniotic fluid level, which is an important factor in our case. The mother is a steroid cover. This is the antenatal ultrasound scan at 32 weeks pregnancy, showing the different parameters in antenatal ultrasound scan. The amniotic fluid, which is equal, adequate in both the twins, twin 1 and twin 2, showing no significant difference. And as far as Doppler parameters are concerned, SD ratio and PI is raised in both in twin 2, which is a recipient donor twin in umbilical artery. The resuscitation details, which is the twins were delivered at 34 plus 2 weeks by emergency cesarean section in view of fetal distress. The twin 1, which is a recipient twins, delivered in a vertex position with birth weight of 1800 grams, whereas twin 2, which is a donor twin, delivered in a breech position with a birth weight of 1440 gram, with the Apgar score of 7 to 8 at 1 to 5 minutes respectively. The resuscitation details. So this is a different presentation which have been opened up. Sanjeev sir. Hello. So resuscitation details, the twin one baby cried immediately after birth, developed respiratory distress in the form of grunting with a Silverman Anderson scoring of 5. After 30 seconds of the birth, baby was put on nasal CPAP further following delivery and shifted to NICU for further care. As far as twin 2 is concerned, baby cried immediately after birth, but due to not maintaining target saturation with a heart rate of more than 100, baby was initially put on free flow oxygen. But on even on free flow oxygen, baby did not attain target saturation, and baby was started on positive pressure ventilation for around 5 minutes. In spite of giving positive pressure ventilation, baby target saturation does not improve with the SpO2 of 60%, and further baby was intubated with ET number of 3, and bag and tube ventilation was continued, and further baby was shifted in NICU for preterm care. Examination at birth, baby revealed twin 1 which appeared plethoric with birth weight of 1800 grams, which the twin 1 is considered as a recipient twin, and with the signs of respiratory distress like retractions, subcostal retraction, intercostal retractions, and as maintaining SpO2 of 89% on CPAP support. As when talking about twin 2, which on birth appeared pale with a birth weight of 1440 gram, with the signs of respiratory distress and maintaining saturation up to 92% on PSV support. The postnatal history, the twin 1 is managed as baby after shifting to NICU was supported on nasal CPAP with a FiO2 requirement of 100 and PEEP of 6. Following which surfactant was given in view of CPAP failure, and was supported further on PCV VG mode of ventilation. Baby was extubated at around 24 hours of life and was further supported on nasal CPAP. Baby respiratory distress improved and further weaned off onto high flow with a FiO2 requirement of 25 and flow of 3 liters at 48 hours of life. And ultimately on day 5 of life, baby was shifted to room air. The baby was managed in view of symptomatic polycythemia because of persistent respiratory distress, and even after administration of the surfactant, respiratory distress persisted. So baby was evaluated on early onset sepsis, following which we revealed hematocrit at 6 hours of life of around 80.3, following which, and also the at birth baby looked plethoric, following which partial exchange transfusion was planned, and baby was done partial exchange. Post exchange hematocrit for the baby twin 1 was 67.2 after post partial exchange transfusion. So we have also evaluated for early onset sepsis, and baby also received phototherapy in view of neonatal hyperbilirubinemia in view of raised TSP of 13.9. During hospital stay, baby was started on IV fluid on day 1, and feeds was started on day 2, which baby tolerated well, which was gradually increased and baby tolerated and gained weight during hospital stay. Twin 2, the respiratory distress is managed as baby was supported on initially on PCV mode with a high FiO2 requirement of 100%, and following which surfactant administration was planned and was given, and gradually ventilatory setting was weaned off. And as the respiratory distress decreased, baby was extubated and put on non-invasive ventilation at 24 hours of life. Further, baby was weaned off to high flow following which there was a requirement of FiO2 of 25% and a flow of 3 liter with a total oxygen days need of 3 days. On examination at birth, baby looked pale and uh, along with the persistent of respiratory distress, we also evaluated for early onset sepsis. On CBC, the hemoglobin at birth was 8.5 at 6 hours of life. The criteria of PRBC transfusion was met, and baby was transfused with 30 ml of PRBC in view of anemia. The twin 2 also received phototherapy for around 2 days in view of raised TSB of 11.04, and baby also received feed, which baby tolerated well. So at 5 days of life, uh, the baby twin 1 had persistent thrombocytopenia with a platelet count of 102, and the sepsis screen was sent of twin 2 because of persistent thrombocytopenia to rule out late onset sepsis. So sepsis screen was sent on day 5 with blood culture. CRP was negative and blood culture was sterile after 5 days. Twin 2 also was evaluated for late onset sepsis, and the sepsis screen was negative with uh, blood culture showing sterile growth. And one significant finding which developed in twin 2 was the features of neonatal cholestasis with the higher amount of direct bilirubin as compared to indirect bilirubin. So, following which the symptomatic measures were started, uh, and at uh, 7th day of life, twin 1, the again sepsis screen was repeated as TL's platelet count was low in view of persistent thrombocytopenia. So the sepsis screen was again negative and blood culture was sterile. At 7th day of life, twin 2 showed increased direct levels of bilirubin, which was 7.3 indirect and direct was 3.3. There was a as there was a persistent thrombocytopenia in twin 1 with the 2 sepsis screen was negative and 2 blood cultures was negative. We have searched literature for the cause of thrombocytopenia in these twins, and we have found that literature also showed that recipient twins have a complication development of thrombocytopenia, uh, which literature also supports. So, as far as the complications of monochorionic twins is considered, we should know about one of the complication, which is twin to twin transfusion syndrome. It is an entity which result from imbalanced intertwin blood flow that causes hypovolemia and oligohydramnios in donor twin and hypervolemia and polyhydramnios in recipient twins. That is the entity called TOPS, twin oligohydramnios polyhydramnios sequence. The presence of this entity, that is TOPS, is pathognomic for twin to twin transfusion syndrome. The pathogenesis which is underlying this entity is based on large placental arterio-arterial or veno-venous anastomosis with a very low resistance, following which allowing large amount of blood to flow directly from the donor to the recipient twins. So there's another entity which we have encountered, which is a newly described form, that is TAPS, which is twin anemia polycythemia sequence, which is it is an chronic or and slow inter-blood transfusion entity, which is characterized by large inter-twin hemoglobin difference without signs of TOPS, that is twin oligohydramnios polyhydramnios sequence. That is, the absence of this TOPS, oligohydramnios and polyhydramnios is an essential element in the diagnosis of this entity. The pathogenesis is based on the presence of few meniscus vascular anastomosis. Now there are two forms of TAPS, which is spontaneous TAPS and secondary TAPS. Spontaneous TAPS is which is occurs spontaneously in monochorionic twin pregnancy, and the secondary is which is due to incomplete laser surgery encountered in TTS cases due to few small residual anastomosis. The incidence is more as compared to secondary TAPS in comparison to spontaneous TAPS, which is 3 to 5% of the monochorionic pregnancy. Now there are the criteria for diagnosis of TAPS, which is antenatal diagnosis and postnatal diagnosis. The antenatal diagnosis is based mainly on Doppler ultrasound, and which include increased middle cerebral artery peak systolic velocity of more than 1.5 multiples of median. That is, it predicts anemia in the donor, and reduced MCA-MBSV velocity of less than 1 multiples of median in the recipient, which show a sign of polycythemia. And along with the absence of TOPS, that is the oligohydramnios and polyhydramnios, that is, there will be a normal amniotic fluid level in both the twins in antenatal ultrasound. As far as our case is concerned, there is no such abnormality seen, so antenatal diagnosis was not considered. Now, coming to the postnatal diagnosis, which is based on hematological criteria, the currently accepted postnatal criteria are: there is twin hemoglobin difference of more than 8, and at least one of the following. That is, if their difference between the hemoglobin of both the twins is more than 8, and along with the one of the criteria, that is reticulocyte count ratio is more than 1.7, which is the reticulocyte count of the donor divided by reticulocyte count of the recipient, which is known as reticulocyte count ratio. And the second is placenta with only small, that is diameter of less than 1 mm placental vascular anastomosis are present on the examination of the placenta. So in our case, this criteria have been followed, and so the postnatal diagnosis has been made in our case. And along with this, we have also seen the short-term hematological complication, which is seen with neonates with TEPS. So the donor twins, that is the twin 2, develop chronic anemia, like with highly increased reticulocyte count, reflecting chronic blood loss. And in literature, this shows that a blood transfusion often needed in first 24 hours of birth in 57 to 80% of the cases. In our case also, the donor twin is anemic and has received PRBC transfusion. So this also reveals literature's correlation. And the recipient twins, that is twin 1, which have received hemoglobin, which has received blood from the donor twin, is maybe severely polycythemic, and also received post exchange transfusion in 40 to 70% of the cases. Another entity, that is thrombocytopenia, which is developed in recipient twins. In our case also, they occur more often in twins affected by TAPS, and is more common among the recipient polycythemic twins. So in our cases also, recipient twins develop thrombocytopenia, which develop on day 1st and persisted till day 7. So this has been also seen in our cases. The cause for thrombocytopenia can be impaired production secondary to tissue hypoxia, and slow spleen blood flow. And the thrombocytopenia in TAPS is mostly self-limiting. The parameters which have been listed in our cases is listed in this table. The uh, uh, as far as appearance is concerned, twin 1, which is a recipient twin, is plethoric as compared to twin 2, which is a donor twin, looks pale, which is a and weight. There's a discordance in the weight of both the twins. Twin 1 weighs 1800 gram, with twin 2 weighing 1440 gram, with a difference of 360 gram, and there's a significant difference of discordance. Length and OFC is not showing any difference, but hematocrit, as you all know, 80.3 in twin 1 and 25.9 with a hemoglobin of 8.5 in twin 2. Inter twin hemoglobin difference is 17.5, which is following a criteria for TAPS. As far as serum bilirubin total and direct is concerned, on day 5 of life, twin 2 develop neonatal cholestasis, following which baby was managed symptomatically, and reticulocyte count of twin 1 is 1.08 with a twin 2 of 15.9, which is a high in case of donor twin, which is also following a criteria postnatal diagnosis of TAPS. The associated hematological complication, which is seen in recipient twins of thrombocytopenia on day 1, which is also seen in our case. So positive finding in our cases is there's discordance in the weight, which is a 20% difference. There's a significant clinical difference in the general examination. Twin 1 was plethoric, twin 2 was pale, with a marginal difference in the hemoglobin between both the twins. And the recipient twin developed moderate thrombocytopenia, which recovered without any intervention by day 10. That is, it is self-resolving. The positive finding indicating TAPS with an interhemoglobin difference of more than 8 and reticulocyte count ratio more than 1.7, along with absence of oligohydramnios polyhydramnios sequence antenatally, a postnatal diagnosis of TAPS was made. So in our case, the recipient twin had another platelet of 70,000 by first day, and which recovers spontaneously by 10th day. Donor twin on day 5 showed features of neonatal cholestasis biochemically, which reached maximum on 9th day of total bilirubin of 7.2 and with a direct bilirubin of 3.6, to which baby was conservatively managed and responded to the treatment. On the 3rd week of life, twin 1 and twin 2 has a hemoglobin of 21 and 10.5 respectively. Biochemical parameter which were followed up between both the twins showed marked improvement at the time of discharge. This is the picture which is showing the difference in the clinical examination, which the twin 1, which is in the right side, was plethoric, and twin 2, which is pale, looks pale. So the learning point, there's a new entity which is TAPS need to be differentiated more from most widely acknowledged twin-to-twin transfusion syndrome. And the difference between those two is summarized in this table. The incidence is 9% monochorionic twins in twin-to-twin transfusion, whereas 3 to 5% in TAPS. The cause is there's large unbalanced inter-twin blood transfusion in TTTS, whereas is slow and slow and chronic inter twin blood transfusion in TAPS. The placenta on examination, the there's larger vessel anastomosis, whereas there are few minuscule anastomosis in TAPS. The antenatal ultrasound shows presence of TOPS. There's twin oligohydramnios polyhydramnios sequence, as compared to there's absence of TOPS in TAPS. The criteria which TTTS follows is antenatal criteria. There's presence of monochorionic diamniotic pregnancy, oligohydramnios in donor, and polyhydramnios in recipient. Whereas in TAPS, we have discussed antenatal and postnatal criteria previously. The morbidity in TTTS is extreme prematurity and development of renal failure during course of illness. But in case of TAPS, there's development of anemia, polycythemia, which is also present in our case. The mortality in twin-to-twin transfusion syndrome is higher because of large blood transfusion between the twins, whereas it is low compared to TTTS in TAPS. So there are four major points which we should know before considering TAPS. The presence of monochorionic twins, absence of TOPS, that is twin oligohydramnios polyhydramnios sequence, and anemia in donor twin, and a polycythemia in recipient twins. And last but not the least, which follows a postnatal criteria of diagnosis, that is difference of hemoglobin of more than 8 between the twins. Thank you.
Very interesting presentation, Vikram.
Thank you, sir.
And Sanjeev, are you around?
Yes, sir. I'm there.
So, as far as the definition goes, it is only the difference in the hemoglobin percentage.
Yes, sir. The first criteria is that in monochorionic twins, with the first criteria is absence of polyhydramnios and oligohydramnios.
Yeah, that is it. But the difference in the outcome is only basically in the hemoglobin.
Yes, sir. It is mainly hematological complications, which are usually milder in variety, and they have less chances of mortality. Other than that, they are more or less a benign entity. Unlike TTTS, which is more severe and where mortality is higher.
But what about the weight difference also? There was a weight difference of more than 20%.
Yes, sir. Weight difference can be there because of slow transfusion from one fetus to the another. There can be a growth discordance in twins in TAPS also. It is as there in TTTS. In twin-to-twin transfusion syndrome also there will be weight discordance. In TAPS also there can be weight discordance, but the complications that is usually seen in TTTS are higher and mortality is higher. But hematological complications, which are more or less benign in nature and which can be managed conservatively also, is more commonly seen in TAPS.
What I'm asking is a significant weight difference also always noted, or there are more or less?
No. Significant weight discordance is not there in the criteria of TAPS.
But here we had a more than 20%.
Yes. Here there was a difference of more than 20%, but it is not an essential criteria for diagnosis of TAPS, sir.
Okay. A very interesting thing that you were bleeding one patient to treat polycythemia.
Yes,
Could
sir.
you transfuse the same blood to the anemic or say baby twin without?
Sir,
since they are monochorionic, we don't expect any blood group differences, minor, major. There was no need of cross. Could we have done it without resorting to, say, exchange transfusion in one and say packed cell transfusion in the other?
Yes, sir. In an emergency cases where we cannot do any other investigations, I think it can be done safely. But most of the unit as a legal procedure, they will not allow this unless and until it is a very life-saving procedure. I think in that case it can be safely done. But since in our hospital policy, all the blood transfusions are cross-matched before giving, so we choose.
Here in this case, if they are monochorionic twins,
Yes, sir.
you don't expect any difference. So there was no need to cross match.
Yes, sir, it can be done, but I don't know how far it will be possible in a hospital settings like this with legalities included in transfusion of blood products. Sir. But
Okay.
yes, it can be done because in some rare cases, even maternal blood can be transfused to the baby, or even the cord blood which is collected can be again transfused to the baby. So here, I think it could have been done easily, but legalities apart, it should have been of no issue.
And we did not subject the placenta to any histopathological examination to.
No, at that time, sir, because till day 7 of life, we were considering this as a case of TTTS only, because there was weight discordance, there was polycythemia in one of the twin with anemia in the other twin. So till 7th day of life, if we go through our note also, the diagnosis was TTTS only, our working diagnosis. But since there was persistence of thrombocytopenia in recipient twin, that made up with a negative blood culture with no other explainable cause for thrombocytopenia, we did a literature search. Only then we came across this new entity of TAPS. So we were,
was in the recipient twin, not in the donor, no?
no, it is in the recipient twins who develops complication of thrombocytopenia.
And what about the direct bilirubin? Why it was raised in the donor?
Yeah, with literature search, we did not found any explainable cause for neonatal cholestasis, and neither we did found any cases where there was association of neonatal cholestasis in the donor twin. But in our case, the donor twin had developed
If at all
neonatal
the
cholestasis. The sepsis screen cultures were all negative, and with the conservative measures, it came down. So what we hypothesize is that maybe because of the chronic blood loss from the donor twin to the recipient twin, the donor twin might have developed some form of hepatocellular injury, which might have caused this neonatal cholestasis. By 3.5 months of age, it was completely gone, and baby is absolutely fine now, sir.
What about the enzymes?
They were all slightly raised. I will not say it was highly raised, slightly raised only. Other than that, there was only the conjugated fraction of bilirubin was raised.
But because we would expect the cholestasis to happen in the polycythemic child rather than in the anemic child.
Yeah, but in anemic child, because of the chronic anemia, that is our postulations only. We did not encounter any such thing.
Hepatocellular injury, the enzyme levels will rise. No?
Yeah, it should have raised, but it was not that much raised to say that, okay, this is hepatocellular injury only. This is our postulations only. We are not sure of that, sir.
And how did we manage the raised bilirubin? What standard protocol he mentioned?
That anti-cholestatic measures were initiated.
Vikram?
Yes, Vikram.
For direct bilirubin, what is the standard protocol?
So we have given the conservative management for the criteria that has been followed in anti-cholestasis measure. There is vitamin A, vitamin D, vitamin E, and fat-soluble vitamins, and along with the these also measures we have given it.
So Sanjeev, how these vitamins will help in removing cholestasis?
Sir, obviously, it was not that hepatocellular injury is the cause. We are not sure of, but with only conjugated bilirubin raised, the vitamins were included as per the IAP algorithm protocol. With that measures only, it came down. In subsequent checkup also, we did not included the enzyme level. We just followed the bilirubin and its fraction level, which came to normal by 3.5 months of age.
Good, see, badhiya. And Vikram, from your end, beta, if you have a presentation, now